Welcome, dear friends. This is Dr. Jaitly, your cardiologist from New York. Here I am on your favorite video site, MuniSTHealth, which has been shown on several social platforms media. And just to reinforce the fact that we are primarily enhancing the medical education and the patient education both to improve the clinical outcomes and therefore the clinical results. And that has been my deepest belief, and it's been shown across the board now by major institutions and colleges where clinical outcomes are only better when the patients have a better handle on their health and illnesses. So without any further ado, I'd like to welcome you again to MuniSTHealth, your favorite video site. A few housekeeping rules, let's put them to the side, and primarily I'd like to say that if you're experiencing an emergency, please dial 911 if you're in the United States, or else get to the nearest hospital if you're outside of the country. And obviously go to the nearest hospital, consult your doctor right away. 2, this is not a treatment advice channel. This is purely an educational and knowledge enhancement informational platform. And 3, for my dearest medical students, residents, and fellows who are taking the exams, etc., please do not consider this as a substitute to your syllabus, because I want you to stick to your own syllabi prescribed to you by your ascribed to you by your by your institutions and of course your colleges. So welcome again. Without any further ado, let's delve into the subject matter. Today we're going to be talking about OSA and its cardiovascular complications. Now, I've already done a video on OSA, the mechanisms. We know that there's an autonomic mechanism which plays a role. There's a hypoxic, hypercapnic chemical mediator response that plays a role. We know there is an oxidative stress which is playing a role. So just to recap, and I refer you to my earlier video on that. But just so that you know, today we're going to be briefly only talking about the cardiovascular complications within this video vignette. The number one is obviously hypertension, because that has been clearly shown both for systolic as well as for diastolic, the pressures are higher. That's 1. 2, we also know that the pathogenesis is primarily because of the norepinephrine levels and the epinephrine levels both in serum as well as in urine. If you were to examine these, they both will be high in settings of OSA. Now, primarily the hypertension is a huge problem, mostly in the rapid eye movement phase of sleep. If those of you are experts in sleep, if they want to know, they can be a little problem there with the blood pressure, mostly in the REM sleep rather than the non-REM sleep, non-rapid eye movements. Now remember, the rapid eye movements normally occur in the waking hours, earlier in the early few hours, like right before you wake up at 5, 6 a.m., etc. So that's where the REM sleep is. But the CPAP has been wonderful, and that's called the continuous positive airway pressure, which actually helps improve the blood pressure, even though if it's dropping by 2 to 5 millimeters of mercury. But that's morbidity and mortality has changed, because now the definition of hypertension clearly says that anything over 125/85 is considered as abnormal. 120/80 is the goal. That's where you want to keep the pressures down too. Oxygen supplementation is excellent also, because that corrects the hypoxia, because hypoxia normally leads to peripheral pulmonary vascular resistance. It also causes systemic vascular resistance as well. So in general, hypertension is all sitting, in the systemic vascular resistance. So, if you are not hypoxic, the chances are your pressures will be also lower. Coronary artery disease. We know that acute myocardial infarctions, unstable angina, they tend to worsen. They tend to occur to a more severe degree, specifically in settings of OSA. Now, OSA, we have already talked about the comorbidities, the cardiovascular, multiple risk factors that are associated with it, like the low HDL, insulin resistance, and then obesity, of course. And then you have the hyperlipidemia, including homocysteine levels could be high. The family history we can't ignore, unfortunately, but the fact is it's there. It can be changed. But the other modifiable factors could be the coagulation factors, coagulative states that can exist in OSA, especially the fibrinogen level is high. The tissue plasminogen activator, we call the TPA, that could be altered. So all these things, they could actually contribute to acute myocardial infarctions in these settings and unstable angina. But the very fact that some of these patients can also have a very tumultuous course, or a very torrential course, sometimes in CABG when they are trying to wean these patients off the pump, or ventilators. Likewise with PCI and CABG, tremendous precautions may have to be taken. And these are all emergencies when you imagine managing these patients for an AMI or acute myocardial infarction. So just so that all of these factors, if you can correct them before or during the time when these procedures are happening, I think the clinical outcomes will be much, much better. Again, a lot of work needs to be done, because obviously if it's an elective procedure that somebody's going for, then of course you can try to get them surgically to lose weight, to get the CPAP or positive airway pressure going at least for 3 to 4 weeks prior to this elective procedure. That is the conventional advice or recommendation to the day of the surgery. And then obviously CPAP cannot be continued during the surgery, but immediately following that, then they can increase or bring back the CPAP again. Now, the other thing is, as I always say, is your atrial fibrillation, which is another area where this is commonly seen, that we have increased tendency for atrial fibrillation, primarily because we know that the left atrial, which is a very thin wall, and that is stretched in the increased intrathoracic pressures. And we know that increased intrathoracic pressures, the negative intrathoracic pressures, leads to the dilatation and stretch of these thin-walled left atrium, and as a result, atrial fibrillation ensues. So it's very crucial that we understand, and all of this is again related to hypoxia and hypercapnia that exists in these patients of OSA. So CPAP is again the answer, and surprisingly, you'll be glad to know that ablation and cardioversion works if you correct the hypoxia and the hypercapnia in these patients before these elective procedures, if you can do them. Pulmonary hypertension is another problem here, as we see, and that normally reflects indirectly because of pulmonary arterial pressure that's elevated, and pulmonary vascular resistance is high. Again, secondary to because of hypoxia, which is low O2 and increased PCO2. So CPAP and surgical weight reduction is the way to go in these patients, and results have been shown that the pulmonary hypertension only gets better in these patients as well, because pulmonary hypertension can be diagnosed by echo, as we know, and I've done a separate video on that, so just to remind you of. And anything more than 20-25 millimeters of mercury within the pulmonary arterial pressure is considered as pulmonary hypertension. So you'll be surprised that just by giving oxygen alone, or oxygen supplementation, or even giving CPAP, you can drop the pulmonary arterial pressure by 5 to 10 points. Sudden cardiac death. Now that's a very, very serious thing. Unfortunately, that occurs in OSA. Some of the mechanisms that have been outlined are QT prolongation, specifically for patients who are prone for certain things. Like QT prolongation will exist when somebody's on a beta blocker or calcium blocker or type 1A or type 1C antiarrhythmic drugs, and amiodarone, for instance. And these patients are already on these drugs. They tend to prolong the QT, and some of the antibiotics can do that. So you have to be very, very careful. Patients who are prone for increased QT prolongation, they can end up in torsade de pointe and have a sudden cardiac death event, SCD. So you have to be cognizant about this. Two, you have to also look for other arrhythmias, like asystole can occur. Non-sustained VTs have been diagnosed, especially on telemetry, when these patients are placed for continuous EKG monitoring. High-grade AV blocks and arrhythmias have occurred, where second-degree Mobitz 2 or even third-degree AV blocks can be detected, and these patients can go into an asystole. So again, oxygen supplementation seems to be working very well. CPAP is again the answer there, but try to correct the QT interval if you can, and of course the underlying heart failure. There is heart failure existing in these individuals. Last but not the least, we have one more. CHF is another area, congestive heart failure, which is again related to increased intrathoracic negative pressures. Now remember, when the OSA occurs, there's a kind of exaggerated Kind-Stokes respirations and apneic spells occurring, followed by hyperventilation, like I showed you in the other video. And the breathing is constantly waxing and waning. These are apneic spells. Then again hyperapnea, and then again hypopnea, and then apnea. So this is apnea, this is hyperapnea, and this is hypo. So Okay, so essentially you get the point where the respiration rate could be totally zero here, pause, a big apneic spell, then the respiration rate starts rising, and the respiration rate starts declining again. So it's all depending upon what the chemical PO2 PCO2 ratio is within the bloodstream, and that is being sensed by the chemical centers in the brain. Congestive heart failure, therefore, can also lead to increased left ventricular and diastolic pressures, and as a result, one sees the mechanisms are explained by reduced preload and an increased afterload. So you could actually help these patients by doing the opposite, by decreasing the afterload and improving the preload in these patients. If you can improve the preload, the chances are these patients can actually do better. The whole idea is wanting to see if CPAP and oxygen supplementation also improves the congestive heart failure, but many times congestive heart failure patients can accompany sudden cardiac death episodes, ventricular arrhythmias of very, very significant nature, so they both go hand to hand, these treatments here. Venous thromboembolism, the last but not the least, is very, very important. Unfortunately, not much can be done because even the CPAP has not really a confirmatory role yet, but increased fibrinogen levels, increased platelet aggregations have been shown in these patients who are sleep deprived, and these are the patients who actually have factor 7 elevations. So nocturnal elevations of all these coagulative states can actually make the person more prone for venous and thromboembolism, including PE, and which is a very fatal disease, as you know, if it is left undiagnosed, especially so if it is moderate to massive in nature. So once again, so the cardiovascular complications to enumerate are hypertension, exacerbation, coronary artery disease, atrial fibrillation, pulmonary hypertension, sudden cardiac death, and heart failure in these patients of OSA. Again, surgical reduction of weight will help in a great deal, but CPAP is the way to go, except there is CPAP which has not have shown any diagnostic roles in venous thromboembolisms yet, but everywhere else it seems to be working very well. Of course, oxygen supplementation and correction of weight is very, very important, and of course the primary underlying other comorbidities that may be existing, including the diabetes and hypertension, which should be addressed as well, because insulin resistance is a huge issue, because that really changes the whole endothelial complex interface. As a result, one can know that the vascular response to various chemical or even baroreceptor or chemoreceptor reflexes can be altered totally if the endothelial dysfunction exists in these patients, which does exist in these patients anyway. So thank you again. Keep promoting the medical education, my friends. Keep sharing with your friends and your colleagues. And of course, for patients, I always say that OSA is treatable, but it's nice to recognize and discuss it out with your patients and with your doctors. And clearly, of course, they prescribe you CPAP. Initially, it'll be uncomfortable, but you'll be surprised that when you wake up, you have a better oxygenation state, and you'll have less daytime sleepiness, etc. So because you have had a good night's sleep, weight reduction is the key, and so in general, again, cardiovascular complications can be reduced for my patients if I speak to them in a very, very simplest of the terms. But again, I think you have a better footing when you go and sit down with the doctors and discuss all these options, and this way they can explain to you even better what the possible complications can occur if you are overweight and you have obstructive sleep apnea. But thank you again. Stay healthy and stay on MuniSTHealth. Keep watching. Until the next video, Dr. Jaitly.